Hello there. My name is Matt Kearney. I'm a GP. I'm a director at UCL Partners, the Academic Health Science Network. I was the National Clinical Director for Cardiovascular Disease Prevention in NHS England and Public Health England, and along with colleagues led development of the National CVD Prevention Programme that was at the heart of the long-term plan. So we all know that much disease, much non-communicable disease is preventable, that the toll that it has on premature mortality and extensive disability is very often preventable. We know that behavioural risk factors like obesity, inactivity, poor diet, smoking are all very prevalent, and we know that physiological risk factors like atrial fibrillation, high blood pressure, high cholesterol and diabetes are prevalent, but they're often undiagnosed and suboptimally treated. But for these lifestyle factors and the physiological risk factors, we also know that interventions work. Increasing physical activity, reducing weight, stopping smoking, treating blood pressure and cholesterol are all very effective at preventing not just cardiovascular disease, but a wider range of conditions also. So the NHS Health Check was established as a systematic, at-scale, population-wide programme to identify risk factors for cardiovascular disease and other non-communicable diseases, and to deliver interventions to reduce those risks. And it was very much the first of its kind, the only thing of this scale that has been done in the world. Very critical, and certainly in my involvement with the NHS Health Check over a number of years now, we've been critical in thinking that the NHS Health Check is not a one-off thing. It is part of a pathway. That pathway goes through primary care. So identifying and then modifying risk factors requires an intervention, and it requires follow-up and through primary care. The long-term plan has set new ambitions, particularly around the high-risk conditions, and has brought new resources and structures to help improve the management of conditions like AF, blood pressure, cholesterol and diabetes. There have, of course, been challenges to the programme over the years and questions raised, legitimate questions around what's the evidence base. Well, we know that all of the interventions in the health check are evidence-based and nice evidence-based, but there's a great lack of evidence to show whether doing it at this scale across the whole population will have the impact on outcomes. Concerns about whether we would worsen health inequalities and only attract the worried well. So legitimate questions to raise. And the studies that we've had so far have tended to be small scale, often local, often not based on real-time data. So the NHS Health Check extract, a GP extract, was established to help us understand what impact the health check is having. It's a huge data set, covering 9.5 million people, 500 million care records. It's a 5-year period, 2012 to 2017, and included about 90% of practices in the country. So fantastic to get such a data set, absolutely huge. It's taken an enormous amount of work to begin processing and learning from that data. And that's going to be the subject of today's webinar. Now, we have, in the last month, published a paper in BMJ Open. It's going to be one of a series of papers drawing on the evidence from this extract. And the first paper looked at uptake and variation in uptake, the quality and completeness of delivery of the health check, and a socio-demographic profile, who is attending, who's not attending, and a risk factor profile. And subsequent papers will look at where is the risk geographically, what's the spread of risk factors in attendees, who's receiving interventions, etc., and moving on to look at impact and lifetime opportunities for prevention. So in the webinar today, we're going to look at the dashboard, and my colleagues Catherine Lagar and Natasha Chetwynd are going to take us through this and help us to understand the dashboard, which I think is a fantastic resource to help us get insight into sort of what are the gaps, what are the inequalities, and what are the opportunities that arise from the health check. So I'm going to hand over now to Catherine and Natasha, and then at the end we will come to questions. So Catherine, over to you first of all. Thank you.
Thank you very much, Matt. So yes, so obviously most of you know on this call we're very familiar with the NHS Health Check program, which is made up of 3 key components: CVD risk assessment, risk awareness, and risk management. It's commissioned by local authority. people are eligible age 40-74 every 5 years if they don't have any existing cardiovascular disease. And although the checks are delivered in majority by general practice, they can also be delivered by other providers such as pharmacy, outreach, or other companies. And the last bullet point is on this slide is the important for us today is that the clinical information generated by the NHS check, whoever is delivering the check, whether it's a general practice or other, the information collected should be returned to the patient's GP and added to the notes. Next slide, please, Alicia. As Matt mentioned, in 2018, we worked in collaboration with colleagues from NHS Digital to extract an England-wide primary care dataset, where participation from by 90% of general practice in England. Altogether, we covered 12 million patients were included in the extract. And as Matt said, I've put here that this led to the production of the first series of paper, which was published a couple of weeks ago. So as you can imagine, from the moment we designed the extract to the moment we produced the first paper, that's involved expertise for a lot of colleagues. Some of them are listed there on paper, but also widely we had contribution from clinician, obviously people, practitioners who deliver the checks and know intimately all the information is recorded or understand very well the data, and then obviously the data science, data management, statisticians, and so on. So it's been a very big team effort. Next slide, please. And in the first paper that we mentioned earlier, and this first paper has been presented in more detail in a webinar we did a couple of weeks ago that's been recorded by Professor Patel, broadly with showing the characteristic of people attending or non-attending an NHS check. And as shown in previous research, we found women were more represented in attendees than in non-attendees. Older people are more likely to attend to. There was a very good access to the program by people from different ethnic minorities, and there was no statistical difference in terms of the distribution of socioeconomic, for example, using the index of multiple deprivation, except maybe at the extreme ends of the spectrum. Next slide, please. And the paper that described the risk factor identified in people attending an NHS check and people non-attending an NHS check. Here I've pulled the information for attendees because our dashboard present data only for the attendees. So on the left on this bar chart, you can see that over 2012-17 overall in England, the program has allowed to identify a fair share of a burden of risk in terms of CVD risk in people attending a check. So 20% of people attending a check were found to have a CVD risk score over 10%. So that's their risk of having a CVD event in 10 years. But obviously, as all big national extract, this probably covers some variation and local variation, and that's what the dashboard will allow us to really drill into. For example, here, if you see on the left on physical activity or inactivity is during an NHS check is measured using the score, the GPAC score. And as you can see when we look at the England data, 1/3 of people don't have a risk in terms of physical activity recorded. But if we picked a local area on the right, we'd call it X, and even if this local area in 2012-13, 1/3 of people didn't have physical activity recorded. When you look in the year 17-18, you will see that they've made a big improvement. Only 10% of people attending a check didn't have their physical activity recorded. So I think that's a good way of showing how the overall England data. Really, it would be important for you to look at your own local areas and with the understanding you have, obviously, of the program you're delivering, commissioning, or you are interested in. Next slide, please. And just before I pass on to Natasha and Liam, who are going to show you the tool, I just want to take this opportunity to again thank all the 90 plus delegates who've helped us design and shape the dashboard. And hopefully when we design the dashboard, we try to keep in mind what delegates have told us. So hopefully you will find that this tool could help you in enabling quality changes in the program in your area or in your local system. Also, obviously, benchmarking, monitoring inequality or inaccess and outcomes, raise the program profile, strengthen the local conversation. It's also a good opportunity to improve data quality and also a way of looking at trend over years. So I'm now going to pass on to Natasha and Liam. We're going to demonstrate the tool to you. Thank you.
Please can I have the next slide? And the next slide again, please. So all of the information relating to the NHS Health Check programme can be found on this webpage on the NHS Digital website. It's either on this link here, you should have the slides, but if not, you should be able to find it through a quick Google search. Everything on the webpage contains useful information about using the data, including data quality information, guidance on how to use the different files on there, and also some supporting information which helps you understand everything that's in there. There's a number of data files which you're able to download, which I'll sort of explain in a bit more detail after Liam's explained the dashboard to you. And then there is also a link to the dashboard, which Liam is going to go through now in more detail, including the functionality of the dashboard and what you can sort of tell from it. So I'll pass over to Liam.
Thank you. Can we go to the next slide, please? Yeah, so when you first click the link to the dashboard, this is the page that you will come to. So it's essentially, you can think of it as a navigation page, in that any page that you want to go to in the dashboard, you can get there from this page. Just whatever page you want to go to, look at the description and click the bookmark tab just next to it and you'll be navigated to that page. You can see that we've got data broken down by local authority and clinical commissioning group. In terms of the actual order of the dashboard, obviously we start with the home page, then we have data quality, so we have just some issues when breaking down the data that should be taken into consideration. We have a national overview, which is just England level figures of attendances and non-attendances, and then after this, all the local authority pages together, all the clinical commissioning group pages together, they both follow the same order. We have an initial overview, patient characteristics, index multiple deprivation, and then we finish with the risk pages. Can we go to the next page, please? Yeah, so here, this is the data quality page, and we just highlight three main issues. So even though we had 90% of practices in England that participated, this will obviously fluctuate by clinical commissioning group and should be taken into consideration. You can see here that only the activity is only the recorded activity in a patient's electronic health record, and there are a number of reasons why a patient would be assigned not attending, and some of them are given there. You'll also see that in the dashboard there's no breakdown for people between the ages of 70 to 74, and this is due to an issue with extracting the data. But all of these issues are really better explained in the supporting information, and on this data quality page in the dashboard is a link to the supporting information. Can we go to the next page, please? Yeah, so here we have the national overview page, which is just really a total count of how many people attended a health check within each of the years. You can see that we also have a proportion of attendances, which is simply the number of people who attended divided by the total number of invites. And you also see here that the non-attendances are broken down further into different groups. You can see that the main reason why people didn't attend a health check is that they didn't respond to their invitation. Next page, please. Yeah, so just before we go into the dashboard, the local authority and clinical commissioning group pages, just want to talk about the selections. You don't have to select just one, you can select single. So wherever there's a filter, you can select single, multiple, or all of them, if you say you want to look at England-wide. and this applies to local authority and clinical commissioning groups. But if you do select a higher order geography, such as STP, then the only clinical commissioning groups you will see will be the ones that reside in that STP. So that's something to take in consideration. If you select a higher order geography, you'll only be able to filter by the lower order geographies that are in that higher order geography. Yeah, next page, please. Yeah, so spent a lot of time going into in terms of functionality, and just going to go through some of the things that really help when moving through the dashboard. Yeah, next slide, please. So when you say if you select a local authority or any of the filters, these get remembered throughout the whole dashboard. So if you select a local authority on the first risk page, you don't have to select it on the other risk pages. But these filters, your selections essentially are remembered where it's possible to filter by that selection. So I've said here that on the risk pages, it's possible to break down by age band. On the deprivation pages, it's not possible to break down by age band, so that will not filter that. So essentially, filters are only remembered on pages where it's possible to filter by that selection. And even though on local authority and clinical commissioning groups, we have year and age band, they're not remembered across geographies essentially. So if you select a year on local authority page, that will not be remembered on the clinical commissioning group page. Next slide, please. And next one again, please. Yeah, so this for both local authority and clinical commissioning group, the first page that you will see is an overview. So we have by financial year, we have the attendees and non-attendees throughout the years 2012-13 to 2017-18. We have a total count of how many people attended a health check in that given time frame. Again, we have a proportion of attendances, which is again the number of people who attended divided by the total number of invites in that financial year. And there's a direct comparison to the England level for people who attended a health check. Next page, please. Yeah, so then the next page is to break down by the patient characteristics. And this basically just gives a breakdown of the number of people who attended or didn't attend by their sex, ethnicity, and age band. And again, you can see there's no breakdown for 70 to 74. But again, information on this is available in the supporting documents. Next slide, please. Yeah, so here we have the index somewhat for deprivation. And you can see that we give a breakdown of the number of people who attended and who didn't attend by within local authority deprivation quintile and national deprivation decile. Also give the proportion of attendances, again, which is just the number of people attended divided by the sum of the invites. And if you select multiple years on this page, then it's possible for a direct comparison. So we can see on this page that in 2012-13 in Cambridgeshire, across all the deprivation quintiles and decile metrics, attendances were a lot higher than in 2017-18. What I will say on this page, it can get quite crowded. So if you just hover over the graph and select the in the top right corner focus mode, which is highlighted there in the red box, then essentially the graph will become the size of the screen, which you will see on the next slide, please. Yeah, so it's possible to select by 6 financial years. So obviously that will get very crowded. So any graph in the dashboard, you follow these instructions and just press focus mode in the top right hand corner, then the graph will become the size of the screen. It's obviously a lot easier to interpret and see the actual breakdowns a lot better. Next slide, please. Yeah, so this is just the first risk page, the first 3 risk categories. So alcohol, physical activity, and smoking status. And the layout for all of the risk pages is identical. And the risk breakdowns that we have, i.e. the categories, are the same for local authority and clinical commissioning group. So the graphs give the percentage of the given sex within each of the subcategories of the risk categories in the selected local authorities, years and age groups, which is a bit of a mouthful. So I've tried to give a bit of an example here. So in this example, we can see that our year is 2017-18, all age groups, Cambridgeshire. So if we look at alcohol use, you can see that 79% of females who meet the criteria in the filters, so 79% of females in Cambridgeshire who attended a health check across all age groups in the financial year 2017-18 had low risk alcohol use. Next page, please. Yeah, so these are the next 3 risk categories, BMI, blood pressure and cholesterol. And you can see that the layout is exactly the same. Next page, please. Yeah, these are the final 3 risk categories, diabetes, cardiovascular risk, family history of cardiovascular disease. And again, these are, if you go on the clinical commissioning group risk pages, they're identical. Next page, please. So when you hover over a graph, what you will see essentially is called the tooltips, and really just give a breakdown here of what you're actually seeing. So the first thing to notice is that our graph is for alcohol use, so that's our risk category, and we've got the subcategory there, so that's low risk. We have a description there of how the risk categories were calculated. So what criteria did someone have to meet to be allocated into that risk category? We also have an actual count of the number of patients in that subcategory that generated the percentage. So if the counts are quite large, but our percentages, so if we had high risk was at 90%, but the number of patients was small, you've got to take that into account when making inferences about the percentages. So that's provided there. So how many, the actual count of people who attended, the actual count of number of patients in the subcategory that generated the percentage. So our national values they're not national values in that therefore every other person. They're filtered by sex, age and year, which allow you to make a direct comparison. So here, the national value, 51%, would be the percentage of females in England who attended a health check across all age groups in 2017-18, whose alcohol use was deemed low risk. And then we can directly compare that to the exact same group in Cambridgeshire, which was 79%. Next page, please. Yeah, so even though I've shown you, we've shown you here the local authority pages, the clinical commissioning group report pages are exactly the same, other than that when we, on the index of multiple deprivation page, there's no within CCG deprivation quintile, so you'll only see the national deprivation decile. Except there again, other than this, they're exactly the same, other than that instead your higher order geography is STP instead of Public Health England Centre, and the lower order geography is clinical commissioning group instead of local authority. I'll pass over to Tash
now. Next slide, please. And next slide again. So I'm just going to go over the underlying data. So whilst the dashboard is great, there is obviously a limited number of functionalities you can do in terms of the graphs and the visualizations. So all of the underlying data is available to download from the webpage, which I showed earlier. There are 4 CSV files, which is just a text file, but they can be opened in Excel. And there is one for each of the different categories noted down here. So age, sex, ethnic category, index of multiple deprivation, and CVD risk factors. So there's 4 for CCG and 4 for local authority. And it literally just provides all of the underlying data in row level data. So if you want to create different visualizations, if you want to do comparisons between LAs or between CCGs, or if you just want all of that data in one place rather than on the visualization, then you can create your own visualizations. You can add it into different dashboards. You can do other stuff with it. It comes in the form that's on the screen at the moment, and you're able to filter by financial year, different geographies, the sex, the age band, in this case the risk category, but that could also be ethnic category, or whichever one we're sort of interested in. And if you need any support sort of using the downloadable data, then we have an inquiries team who will be happy to help with all of that, and the information for them can be found on the webpage as well. I think that's all from us. Next slide, please. Yeah, I think I'm passing back to Matt.
So thank you very much.
Maybe just before, I think Alicia, on the last slide, there's the links interesting links if people want further links to the paper, the dashboard, and the business rules. Sorry.